the final segment of the session will follow an interactive format, combining discussion and case example, clarifying ovarian pathology by Nina Cooper and Wouter Froyman. And briefly, Dr. Nina Cooper is a clinical research fellow and PhD candidate at Imperial College London and a key researcher within the IOTA collaboration. She leads international multicenter studies on adnexal pathology in pregnancy and in young patients, with a strong focus on ultrasound and gynecological oncology. And Wouter Froyman is a professor of obstetrics and gynecology at University Leuven and a member of the IOTA steering committee. His clinical and research interests focus on gynecological ultrasound, adnexal masses, and minimally invasive surgery. Please welcome Professor Wouter Froyman and Dr. Nina Cooper.
Hello, thank you so much for the kind introduction. I hope you can see my screen. So just to begin, I want to make some acknowledgements. So thank you to the following clinicians for their contribution to these slides. And these are mine and Wouter's conflicts of interest. So we've just heard about the two-step strategy. So the first step is asking yourself the question, can I apply an IOTA benign descriptor? And if you can't, the second step is to then apply the adnex model. The benign descriptors, as Prof has outlined, are simply put 4 classic benign lesions. All 4 of them can be applied in premenopausal women, but only descriptors 3 and 4 can be applied in the postmenopausal population. And they essentially describe typical endometriomas, dermoids, simple benign simple cysts, and other unilocular cysts, all measuring less than 10 centimeters in size. When you can't apply them, you can use the adnex model as your second line approach. And this allows you to generate a risk of malignancy. And using your risk of malignancy, you can then use the ORAD system, if you wish, in order to guide onward management. The first case I'd like to talk through is a 45-year-old woman who has regular periods. She was found to have an ovarian cyst whilst undergoing fertility investigations. And she had a history of a previous lap and dye test with tubal clipping. So in the cine clip on the screen, you can appreciate a unilocular cyst with ground glass echogenicity and smooth internal cyst walls. And for the keen-eyed amongst you, you can notice that there is also a second cyst within this ovary with very similar appearances. The colour score here is described as 1, so there is no colour flow to this cyst. And so this has quite typical appearances for a certain type of lesion. So if we ask ourselves the questions, number of locules, 1, presence of solid components, no. I would describe it as having ground glass content, no acoustic shadows, and no ascites, with a colour score of 1, measuring around 2.5 centimeters in size. And so the first step of the two-step strategy is to ask, can I apply the benign descriptors? And in this case, yes, I can apply the benign descriptors. This is a typical benign endometrioma. And so this patient was managed conservatively. So using the two-step strategy, I can apply benign descriptors, which means that this is almost certainly benign, and therefore it is reasonable to manage this patient conservatively. Moving on to a second case. This is a 67-year-old patient with a history of a total abdominal hysterectomy and bilateral salpingo-oophorectomy performed about 40 years ago. Histology showed at that time that part of the ovary remained in situ, and she presented to clinic with a large pelvic mass and bloating. So as you can see here, there is a multilocular lesion with more than 10 cyst locules. There's no convincing solid papillations. It just looks like quite dense multilocular structure, which we may describe as honeycombing. The content of the locules could be described as anechoic and low level, no convincing acoustic shadows. I haven't shown you the colour flow, but the colour score of this lesion was 2 to 3, and her CA125 was done and it was 16. So the first question to ask yourself in the two-step strategy is, can I apply the benign descriptors? Well, cheating, it's very easy to say no because this is not a unilocular cyst. So no, I cannot apply the benign descriptors. So the next step is to apply the ADNEX model. So this just shows the ADNEX app, which is available, and you can use it on your phone and input the patient information. So she's 67. She was scanned at an oncology center. This is a 189 millimeters, so almost 20 centimeter lesion. No solid component, more than 10 cyst locules, no papillary projections, no acoustic shadows, and no ascites. And the ADNEX model will produce a overall probability of this being malignant, so 29%, which would determine it to be an ORADS4 lesion with an intermediate risk of malignancy. It will also provide a breakdown of the relative risk of malignancy for each type of tumour, so whether this is a metastasis, a stage 2 to 4, stage 1 or borderline. And as you can see, the greatest relative risk is for a borderline ovarian tumour. So the greatest suspicion is that this is a borderline. Now, what happens if we use CA125? So you don't have to use CA125 when using the ADNEX model. However, it does provide you a slightly different risk of malignancy here. So as you can see, the CA125 was the normal limit. So the probability of this being a malignant tumour was slightly lower when we put in the CA125. But still, the overall relative risk of malignancy was still greatest for a borderline ovarian tumour, with a lower relative risk of a stage 1 to 4 cancer or metastasis. So this patient was managed surgically. So step 1, we cannot apply the benign descriptors. So step 2, we applied the ADNEX model, which provided an intermediate risk of malignancy, and so she was referred to a gynae-oncologist for onward care. The final case that I'm going to talk about just outlines a common pitfall that you may fall into with using the two-step strategy and how to make sure you don't do that yourself. So the final case that I'm going to talk about is a 67-year-old woman who was investigated for nausea and vomiting, and there was an incidental finding of an ovarian mass. She was found to have a raised ALT, but otherwise no other gynecological pathology. So looking at this lesion, I would describe this as unilocular with anechoic cyst content, smooth internal cyst walls, and measuring it, the maximal diameter of the lesion was 110 millimeters. So the first question is, can I apply the IOTA benign descriptors? And the answer is no, because although this cyst has benign appearances, it measures over 10 centimeters in size, and so we cannot apply benign descriptor 3. And so you either use subjective impression, expert assessment, or apply the ADNEX model. Again, inputting this information into ADNEX, 67, oncology center, yes, maximum diameter 110, no solid components, fewer than 10 cyst locules, no papillary projections, no acoustic shadows, and no ascites. And so the risk of this being a malignant tumour was overall 8.8%, which would make it an ORADS3 lesion, low risk of malignancy. And again, looking at the subtypes of all different types of cancer, incredibly low risk for any malignant lesion. And so, although we can't apply the benign descriptors, we can say that there is a less than 10% risk of malignancy, so a low risk of this being a cancerous lesion. And so she was referred to a local gynecologist. And as she was asymptomatic and there was a low risk of malignancy, we were able to manage this patient conservatively. I'll hand over to Wouter Froyman now to go through the next cases.
Thank you, Nina. It's a pleasure to be back. I will have 2 cases left for you to discuss with you. So the 4th case is 21 years old. She's premenopausal, and it was an incidental finding of a cyst. So you can see here at the start of the clip, you have the ovary, the normal part of the ovary, so the normal ovarian crescent sign. And then next to that, but attached to that, you can see that there's a cystic lesion, also with a solid component. So in the center, you can see that there's solid looking tissue. Of course, we have the proof that it's solid if you put on the color Doppler. You will see the viscolarity inside. So it's by definition a solid component. And as it comes from the wall of the cystic lesion, and it's protruding inside the cyst cavity, it's also fulfilling the definition of a papillary projection. So the height is at least 3 millimeters. We have at least one diameter of 3 millimeters, so it's a solid component, and it's protruding at least 3 millimeters in the cyst cavity. So we have the definition of a papillation. Going back, Nina, maybe to the previous slide, sorry for that, we see that the cystic area is quite anachogenic, as you can see. And it's attached there to the ovary. So you can see the normal ovarian stroma, and then you see this bridge of a vascular supply towards the lesion. So part of the ovary is normal, and then attached to that normal part of the ovary, we have the lesion. We cannot explain this by normal physiology. So the color Doppler, it's not minimal. We don't need to search to find the vascularity. I think looking together at the solid component and the wall of the cyst, we can assign color score 3. Behind the solid component, you can also see in the direction of the ultrasound beams, you can see some loss of acoustic signals. So we see the stripy shadows. There are some hyper-reflective areas inside the solid component, and behind that, we can see acoustic shadowing. So we have a lesion that contains cystic and solid components with acoustic shadowing. I just have to see again, Nina, if you have more videos to see if we have a septum inside or not. So here, maybe this first video. So it seems like we have two separate cystic areas inside and a solid component, so a multilocular solid lesion. Yes. Maybe there are also some pseudosepta, so which are not attaining the other side of the lesion in all scanning planes. So we have a pseudoseptum, at least one, and then maybe, yeah, it could be a unilocular solid lesion if there's not a complete septum visible. Okay, so then we will try to assign a diagnosis. So the first step of the two-step strategy is, can we apply any benign descriptors? I would let you think first. Some might say, yes, I can apply maybe descriptor 3 because it's unilocular with an anachogenic content. Be careful, we cannot apply the benign simple descriptors because there is a solid component. So as from the moment you have a solid component in the lesion, you cannot apply the benign descriptor. So here we have a solid component, so no, the descriptors are not applicable. So the second step is we have to go to the adnex model. So we have the age, oncology center, so the clinical variables. C1 to 5 is optional, as said, so we do not need it to distinguish between benign and malignant. But if we have a malignancy, it will help you to define the subtype of malignant tumor. So the size, we have to measure two things here. The largest diameter of the lesion, 64 millimeters. The largest size of the solid component, 17 millimeters. We have not more than 10 locules. We have one population, we have shadows and no SIDs. So we can calculate now the total risk of malignancy. So the malignancy risk is 3.5%, as you can see here. It's below the cutoff of 10% that we suggest to have a suspicion of malignancy. So we can classify this as an ORAT 3, a low risk of malignancy. This means that if you follow the ORAT strategy, we are there. We can look at the clinical presentation of the patient. This patient could be managed with surgery by a general gynecologist, for instance, with laparoscopy. And that is what was done in this patient. So we observed actually a torsion of the pedicle in the right side here in this adnex. So you can see the tube and the infundibulopelvic ligament that are twisted there on the right. We see the normal part of the ovary as we saw on the ultrasound, the ovarian crescent, and then next to that and attached to that, we see this cystic lesion with a solid component, which is not visible behind. So there was a torsion of the right adnexa, and the histology was a serous cystinofibroma with a limited proliferation, so less than 10% in the epithelium. So if it would be more than 10%, it would have been classified as a borderline tumor. But as it was less than 10%, the proliferation, it was classified as a benign tumor. So benign cystinofibroma of the ovary. So we did a ovarian sparing surgery, a cystectomy. The last case for this case discussion is also a young patient. She's 21 years of age, obviously premenopausal, and she was referred because of bilateral cystic masses. So you can see here the pictures of the ovaries. So we have large tumors, so right side and left side. So we can see that we have multiple papillations. So we have multiple solid structures from the wall of the cyst protruding inside the cyst cavity. So you have separate papillations, but then on the top you can see there are also confluents. So there's one papillation going over to the next. So we have a lot of dissemination and confluent papillations present. It's on both sides the same type of image. So we see the two nexa are enlarged because of these unilocular. We don't see a septum unilocular solid cysts. There is clearly vascularity inside. So if you assign the vascularity score, the color score, you look at the solid part of the cyst, because there is where you expect the vascularity. And especially on the right side, it's well vascularized, the lesion. The content does not seem to be completely aneuploidic based on these 2D grayscale images, these still images. It looks a little bit of low-level echo, especially the lesion on the right side. The contours of the papillations are clearly irregular, and you can also see in some of these papillations some small cystic areas, this microcystic pattern. You see the largest size of the largest solid component here is more than 5 centimeters, so it's a very big papillations inside these lesions. Some might see maybe that there's some shadowing, but I would like to go back. So here you see that the shadows is coming from the edge. Yes, it's coming from the edge of the lesion. So it's the interface there on the right side. You can see it is the interface between the cyst wall and the bowel. So at the edge of the lesion, you will often see shadows, but this is not really counting as internal shadows. It's not coming from the lesion itself. So these are the 3D reconstructions of the surface inside. We see the irregular papillations present on both images. And then we have here two lesions that have a similar morphology. They are both unilocular solid. Unilocular because we don't have a complete septum, and solid because we have obviously a lot of papillations. So then if you want to look at the risk of malignancy, we will start with the dominant lesion. So it's the lesion if they are having a different kind of morphology. So if you have one lesion that is solid, and on the other hand, on the other side, you have a unilocular cyst, then you will look at the risk of malignancy for the most complicated morphology, the most complicated tumor type. So that will be the solid tumor. Here we have two unilocular solid lesions, so they have similar morphology, but then we will look for the largest one. So the largest lesion we will look at to assign the risk of malignancy. So the first step, can I apply the benign descriptors? Again, this is again a case where many people would be confused and they would say, yes, it's a unilocular cyst with papillations, but this is not possible. Then you have a unilocular solid lesion. So again, from the moment that you have solid components, please, you cannot apply the benign descriptors. This is very, very important to remember, otherwise you will make mistakes. So again, we have to go to the second step, the Altnex model. We have again the clinical features which are filled in, the largest dimension of the lesion, largest dimension of the largest solid components. We have less than 10 locules, we have more than 3 papillations, we have no shadows, no ascites, and we have serum C125, which we can't fill in if we have an increased risk of malignancy. So here we see again the total risk of malignancy on top, so 92%, which is way above the cutoff of 10% to suspect a malignancy. So that's the first step in this Altnex model, the total risk of malignancy. And then besides that, we look at the subtypes of malignancy. And then you have the absolute risk, which you see the percentages of in the middle. So the highest risk is here for borderline is 33.8%, followed by stage 2 to 4 ovarian cancer. But besides this absolute risk, we also look at the relative risk. So we look at the change in the risk. So from the baseline, from the IOTA cohort, IOTA phase 1 until 3, towards our patient. So here our patient has a relative risk of factor 5.4. So her risk is 5 times higher of having a borderline compared to the average IOTA 1, 2, and 3 patient. So we look at the absolute risk of malignancy, but also the relative risk. So it's ORADS 5, it's up to, more than 50%, high risk of malignancy. So we refer the patient, or we will at least discuss the patient with our gynae oncologist. So this patient was operated on by laparotomy because we did not want to risk a spilling of the cyst. So there were no other lesions observed besides the 2 adnexa. So she had a laparotomy with a staging, and it was a bilateral borderline tumor, so stage 1C3 with microinvasion on both sides. So to summarize again, so first step, we don't need to apply adnex in all the patients. So many patients, so between 30 and 40%, we can apply the benign descriptors, but don't be confused, don't make mistakes there. So you can only apply it if the cyst is unilocular. And for some of the descriptors, you need also the menopausal status, so premenopausal patients for the dermoids and the endometriomas. And the size needs to be less than 10 centimeters. This is very important to remember in order to apply the benign descriptors. And if you cannot apply the benign descriptors, we go to adnex. Adnex you can use in a first step for calculation of the risk of malignancy. So you don't need C125 to do that. But if your risk of malignancy is increased, so more than 10%, we will recommend you to use also C125 because it will help you to distinguish between the subtypes of malignancy as you have seen in the cases, which is very important for the clinical management of the patient because your treatment of the patient will be depending on the suspicion of the type of malignant tumor. So thank you so much for your attention. These were the 5 cases, and we are open for any questions from the virtual floor.
Yes, we have. Actually, we have a question. Are we ready to discuss it?
Yes, of course. Yes, go ahead.
We have a question from our participant, and I believe that it's can be addressed to Wouter. Postmenopausal with solid mass cannot differentiate uterine pediculated fibroid versus ovarian mass. How to consult? Would you offer surgery irrespective?
I think it's a good question, and I also think that it can also be in premenopausal patients. So to distinguish between a pedunculated fibroid or an ovarian lesion. So first of all, you can look for a connection between the lesion and the uterus. And often if it's a fibroid, you will see a stalk, which is quite rigid, quite thick. You will see a vascular bridge between the lesion and the uterus. So this would be typical for a uterine lesion, a fibroid. And if you see, of course, on that side or on 2 sides, a normal ovary, you know it will be a uterine lesion. So it's also useful to use your contralateral hand if you do vaginal ultrasound to push also on the lesion to see if it's mobile from the uterus. Again, a pedunculated fibroid will be more difficult to move away from the uterus compared to an ovarian lesion. So, but if you think it's not, so if it's uterine, it's menopausal, of course, it's more reassuring. But if you are not sure, it could be ovarian. So then we have to look at the features. We know that solid ovarian lesions are the most risky. Yeah, they have the highest risk of malignancy. Despite that, there are some features that are very typical for a fibroma of the ovary. You have a well-delineated lesion that has acoustic shadowing, that has not a lot of vascularity. But despite that, we know that although you expect that it could be fibroma, we have looked at that in the IOTA study, that the risk of having a malignancy is quite high. It's still 3%. So the risk of malignancy is still high in a benign-looking ovarian tumor that could be a fibroma. So you have to be careful with ovarian solid masses And I think the threshold for doing an intervention should be quite low in those patients if you think if it's ovarian. But I'm not saying that all solid lesions in the ovary should be removed if you think it's a clear fibroma. It's also depending on the symptoms of the patient, if about comorbidity, surgical risk. But I think those are the tricks to differentiate between a uterine fibroid and an ovarian lesion. And then the message is pay attention with solid lesions from the ovary. Fibromas or fibromas with ovary have some features that you can recognize them, but still it can be tricky. And
Do you ever think MRI adds anything in those? Because sometimes MRI is quite good at looking at cross-sectional relationships. If you don't see the ovary on vaginal ultrasound, just for discussion purposes, would you ever, for example, say, well, let's do an MRI and see, because maybe the MRI will see a connection with the uterus that you've just missed on ultrasound, or see the ovary in a cross-sectional plane, which you've not been able to see. Would that be an option, or do you think it's not worth doing that?
I think it is. I think it is an option, because sometimes, depending on the constitution of the patient, also if she had surgery and the ovary is in an abnormal position, I think MRI can help you to identify the origin of the lesion. If it will help you to say whether it's benign or malignant, that's another question. MRI also struggles often in cases where ultrasound struggles. And
yeah, but I mean, the obvious thing is if you can see the normal ovary separate, that helps you, right? So it's not about the kind of nature of the mass, so to speak, but that's your first discriminator. If you see this as something like this, is can I see a normal ovary separately? Because that's basically the first thing.
Sure.
I think we always do. Yeah, I don't know. Sorry, Inessa, excuse me. Go ahead.
No, I've got an answer. Thank you for this. And we have one more question in the chat box, and I have my own question. Do we have time?
Yeah, we've got a minute or two.
Okay, I will feel free. Okay, we have one question probably for you, Tom. If there any app or online site, for example, Denia, where someone can calculate freely aorta adnex model, we need some clarification concerning adnex model availability for now.
Well, Dirk also probably knows more about this than I do at the moment, but excuse me. It's difficult for two reasons. It is available on the Guinea site, but at the moment, the key issue for us has been something called MDR regulation, where adnex, unfortunately, has now become a medical device. In fact, all models have become medical devices, and that is created a lot of difficulty because it's very expensive. We're talking, six-figure sums of euros to get it through medical device regulation, which means we've created an entity called Guinea, which is running education and also is availability of the app. Currently, the adnex app is not available in all parts of the world because of regulatory reasons, but will be hopefully soon. Although I think it's just become available in the United Kingdom because they have different regulatory authorities to the EU. So this has been a change that's happened over the last year, which has created problems for everybody, and it's going to be a big issue for research. So direct answer to the question is, unless Dirk, do you want to chip in here? You might have something to say. It's available on some ultrasound machines at the moment still, but unfortunately our online free calculator is no longer available for the reasons I've just said. Do you want to add anything to that, Dirk? Or?
No, it's correct. We offered it for 9 years on our website for free, but we had to stop it because it's illegal to offer any data to the outside world if it's not with a CE label in Europe, FDA label in United States, or UK label in the UK. So we luckily now have the UK label, and we hope that over the next month we will have the CE label as well. And then it can be clinically used again.
Okay, I know that many people really wait for this tool, rely on this, and wait for.
Yes, but in the meantime, it's built in many ultrasound machines, so people can use the adnex model, but it's only the app is a medical device. But the model has been validated in over 100 studies globally. So it's reliable. So we know that it's reliable and it can be used, but we cannot offer it.
Okay.
Thank you. And we have one more question, and I believe it's interesting. It looks naive, but it's a very practical one. Probably for Nina, I don't know if you don't mind. Sometime the loculation of an inclusion cyst can't be differentiated from a suspected cystadenoma. What is the next step? It happens really.
Yeah, so peritoneal inclusion says there are some tips and tricks again for differentiating them from cystadenomas. So first of all is assess the clinical picture of the patient. So if she's got a history, previous pelvic surgery, previous pelvic infections, your index of suspicion for inclusion cysts will be higher. I think also pelvic TB, you can see inclusion cysts. Secondly, there are other things you can look for on dynamic scanning. So the flapping sail sign, where essentially you use your probe to push on the cystic area, and you'll see flapping of septations. That's probably what I do most often to try and differentiate from peritoneal inclusion cysts. Obviously, I think we've spoken about the fact that where you have uncertainty, if you can refer to an expert centre nearby, if that's feasible for another ultrasound, or of course cross-sectional imaging with MRI if you don't have access to that. But I think dynamic scanning in your clinical context are the most useful things.
Thank you.
Okay. There's one more question I'm just going to answer. It says, if we can apply benign descriptors, is it better to do a CA125 for confirmation? No. There we go. That was short and sweet. It doesn't help, and CA125 honestly is not a great test, and I really would encourage people that in that situation it's really not necessary, especially with adnex. With adnex, again, if you're actually scanning the patient, you don't need CA125 to come up with a risk. If the adnex designates it as being probable malignancy, then CA125 can be helpful to subclassify the malignancy. So that's where CA125 sits, and then obviously in management thereafter if it's cancer, but not in that immediate diagnostic situation. We don't need to do it.
You even can't imagine how many doctors still rely on CA125 in terms of differentiation between benign and malignant. It's a disaster to confirm that not to do it, not to rely on this test.
No, I 100% agree with you, and I just thought that's why it's worth mentioning that question, because it does come up, but really it's not necessary. I've been told there's the messages coming up here. Can we close, please? It says here from Rochelle. So, Inessa, can I leave it to you to close this session? And we're back at 12 o'clock at UK time. Inessa, I'll hand back to you to finish off the session, if that's okay.
The short recap. Thank you. First of all, thank you all the participants. It was such a pleasure and honor for me to introduce your names and your works. Thank you very much for all the participants who were online, and we hope that many of the pre-registered participants will watch this course virtually later on. Thank you very much, Tom, and personally for you. I wish you to stand all this load today. The entire day you will chair in this session. I wish you to have the successful continuation of this course.
Thank you, Inessa.